And I will approve that. Okay, so you can go ahead and go to the next slide. So I was asked to present on the AIM sepsis bundle, and we don't have an AIM sepsis bundle yet. It is in the works, it's in progress. Their plan from AIM National Office is that the bundle will be ready sometime in 2022. So I will keep you guys updated with that as AIM comes out with that information. I will say, because we did talk about the other bundles previously, the cardiomyopathy bundle has been introduced, and there are some hospitals and facilities that are going to start working on that. If you try to go on the website for AIM, it's not loaded up yet, but it's all in that process. So we should be able to have access to that if anybody is really interested in working on that one coming up. But in the meantime, we do have the California Maternal Quality Care Collaborative Toolkit. And this, we tend to follow, California sort of does a lot of the groundwork, and then we're able to adopt that and make that work for multiple facilities and states around our nation. So next slide. So this is really what I'm going to work through today. The one big thing that that we get questions about is why do safety bundles, why do toolkits, and this is why. Because we know that sepsis is a leading cause of maternal morbidity and mortality. Across the US, the last data that we can find is it's around 12.7% of maternal deaths from sepsis. We know that hemorrhage and hypertension disorders are all important toolkits, and they all merge together. When we look at South Carolina's data specifically, you can see on the right-hand side of the slide, our March 2020 legislative report from Maternal Mortality Review Committee listed infections as our #2 cause of death. When you look at the 2021 legislative report, it dropped down a little bit, and we are down to 14% for our infections. But I have a sneaking suspicion that with the current state of COVID in the last year and a half, going on more than that now, that we're probably going to see an increase in sepsis related deaths for our moms, unfortunately. So it is important. It's something that we need to highlight and pay attention to. Next slide. From CMQCC, they do list leading causes of maternal sepsis, and they broke it out into antepartum, intrapartum, and immediate postpartum, and then our post-discharge, because that's the same way that we look at our maternal deaths. We look at our maternal deaths while our moms are pregnant. We look at them at delivery and right after delivery, and then we look at that postpartum time period. So I think it's important to just take a look at these to see, because I know just glancing at these, you think about how many moms we see on a regular basis, either in the hospital or in the office, that are dealing with these types of infections. And what you see across all three related to what we're doing right now, pneumonia and influenza is popping up. So this is why we're just sort of keyed into this right now. Next slide. So the CMQCC's Quality Improvement Toolkit is broken up into 5 different parts. The first is screening and diagnosis of sepsis. The second is assessment and treatment of maternal sepsis with different care bundles. The third is assessment and treatment of maternal sepsis, looking at both antibiotic use and source control. Part 4 is obstetric considerations within just that very specific. We're dealing with a pregnant or early postpartum woman. And then the last part is discharge education. And we've really started highlighting in the last several years the importance of that discharge education, whether mom is postpartum or antepartum when she is discharged from our care. Next slide. So what I did for us is broke down what these different sections or parts of the toolkit are. And the biggest part, and what CMQCC and their data has found, that assessment and screening is really key. And so they developed the best way to not only have screening across the board, but they do a 2-part screening process. So we know, number one, that when we think about pregnancy and that pregnant physiology, a lot of the physiologic changes of pregnancy are will mask some of the signs and symptoms of sepsis, and they appear differently in our pregnant population and early postpartum population. So the recommendation out of California is that there is a two-step process of diagnosis, and we're going to look at that. Worldwide, the World Health Organization has defined maternal sepsis as being a life-threatening condition with organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion, or the postpartum period. And so that is a little bit different when you look at definitions of what sepsis is in the non-pregnant population. Next slide. So the two-step process is, I think, what we want to spend some time talking about at the end of the presentation, and I think that's what we're going to highlight with our case. So California has said we're going to do an initial sepsis screen for all patients who have a suspected infection, and this is if I have two or more criteria, so a temperature that's elevated or low, a heart rate that's elevated above 110 and sustained, a respiratory rate that's above 24 and sustained, and then an elevated white blood cell count. Or, and we'll look at labs a little bit differently, and you can see the table listed on table 3 with a little bit more specifics there. And that's for end organ damage. So we're going to be kind of going between, are we seeing initial signs of infection? And then are we looking for, number 2 is there evidence of end organ injury? So this confirmation of sepsis moves into that step 2 of the screening process. So once we've screened that patient in for sepsis, then we're looking for confirmation of sepsis, and then is there recognition for end organ injury? The Centers for Medicare and Medicaid, so CMS, also have core measures for sepsis and definitions, looking specifically at suspected sepsis characteristics and parameters, which is why it's important for us to make sure that we're paying attention to these specific lab values and or bedside assessments. Next slide. This next slide provides a really nice flowchart. I'm all about algorithms and flowcharts because I think that helps our brains be able to think through the patient process. This is, and by the way, anyone can go on to the CMQCC website and log in and download this toolkit at no cost. You may have to register, but it is a no cost registration. So this gives us that nice kind of flow algorithm for taking care of our patients. Again, looking at that step 1 initial sepsis screen with that suspected infection. If we have positive 2 or more criteria, then we move into the confirmation of sepsis, and you can see that next big blue box there. And then we'll kind of go into action and treatment as we kind of follow through with the rest of the parts of the toolkit. We need to remember, number 1, that all members of the clinical team should maintain a high index of suspicion and embrace our non-hierarchical communication. It's one of my favorite sentences I think I've ever seen in a bundle, that we have to highlight the team member communication. If a nurse or a provider, a lab tech, a scrub tech, a nurse tech, whoever is picking up on, there's some vital signs that seem a little bit off, that should be communicated. It doesn't matter who you are, a first-year resident to an attending. Everyone should be able to be open to say, I'm concerned about this. So I know Dr. Campbell and I often agree on everybody is an important part of the team and we have to communicate that information. So we'll kind of dive into that a little bit more. Next slide. So once we've diagnosed and confirmed that we have a woman with sepsis, the key principles in this next part for treatment is, number 1, act quickly upon recognition of those signs and symptoms. We want to minimize time to treatment because we recognize it's a medical emergency. And what we'll see in a lot of cases is pregnant women are good until they're not. So they can very quickly make that turn to have a more severe illness. So we want to be very, very attentive to the fact that we can have a mom who's doing very, very well, and then 15 minutes later, she crashes. So we want to pay attention to that. We want to look for, when we're doing treatments, lack of response to those treatments. So if I'm doing interventions and she's not responding appropriately or in the way that we think she should be, then we need to elevate or escalate our care. And again, that communication of that maternal status is very, very important through all patient care communication and all handoffs to wherever that patient is going. So what they like to talk about throughout this bundle is, when do we start the clock? When do we start that time zero and then moving forward within that process? Next slide. There is this great graph, or not graph, but table that is in the bundle that talks about the frequency of fetal monitoring, pulse oximetry, blood pressure assessment, temperature assessment, urine output, and mental status for that, when we start time zero and then when we need to move forward. And I think that that's really important to make sure that everyone on the team, when you are recognizing that there's the potential for sepsis with our patient, that we are all on the same page with how those assessment parameters need to move forward. Additionally, we start moving into what kind of blood cultures we need, what kind of fluid management, what kind of IV fluids does she need? Do we have rapid response within our facility, and how are we going to activate that if we need them? What are going to be our parameters for activating that rapid response? For example, if the work of breathing for that woman becomes too hard or too high, and that what is that level? So we need to be very aware of what our facility parameters are, and then distinguishing what kind of infection we have so that we know how to start some of that treatment. Next slide. When we start talking about treatment with antibiotics, and I am an RN, I'm a nurse, and I will let Dr. Campbell ask or answer any specific questions about antibiotics. But what the focus of the toolkit is that we get early administration of antibiotics, ideally within 1 hour of presentation. The initial choice of antibiotics is generally going to be a broad spectrum antibiotic until we get more information on what we're dealing with. And then we need to look at source control. So we want to look at, is there an incision? Was this mom, did she have a C-section? Could that be the possible source of the infection? Did she have a cerclage in place? Does she have a central line in place? Where could that source be? So within those antibiotics, we want to start them early and then follow up with whatever those cultures are, and then start looking for where the source could have come from. So we want to see, do we have sepsis order sets? And we also want to not forget about pain medication when we're talking about taking care of these mamas, because we want them to be as comfortable as possible within this process. In one of the other things that we're thinking about. So pain is always an issue. Next slide. What I tried to do within this slide is take the information that was in the toolkit and try to make it, hopefully it's not too teeny tiny on your slides, but we can share these slides with you, and obviously you can go to the source and see these. But what they've said is, we've got patients that we have identified sources of infection. There's a possible drainage that we're looking at and seeing, and what we need to process through that. If it needs to be that we get infectious disease involved, we get interventional radiology involved. And then we've got patients that in the purple in the middle, patients that have identified sources of infection requiring surgery. Who do we need to consult for that? So does she have some fasciitis going on? Do we have a perineal abscess or a pelvic abscess? You know, what else is happening, and who else should we be consulting? And then the dark purple on the far right are patients that are identified with sources of infection that are too small, or we're not seeing them, we're not seeing anything draining. So there's something kind of what we consider that hidden kind of infection that we can't actually see. So then what other studies do we need to have? Do we need to get infectious disease involved? And I would say that Dr. Campbell will probably say yes. That's one of the top people that we're going to get calls. And then if you are working at a level 1 or a level 2 or even a level 3 facility without maternal fetal medicine, we want to make sure that we're consulting with maternal fetal medicine, so that if we need to move that woman from a lower level facility to a higher level of care, that is also very, very important. Next slide. So these are just some additional obstetric considerations that are highlighted within the toolkit. Timing of delivery is going to be very important. Sometimes it's about balancing, I would say not sometimes, but all the times it's going to be balancing the maternal overall health with the fetal health. So we have to walk that kind of tightrope of how is mom doing, how is baby doing, and at what point do we need to say, okay, babe and mom are going to be better with delivery. We want to have specific anesthetic considerations. You know, is she going to be somebody that we're going to need to use general anesthesia, or can we use a spinal for her? When we're looking at our screen positive patients, remember, we're going to be continuing to follow those labs and vital signs very, very carefully. And then we need to be monitoring for, or do we have a patient that's going into shock? So we have very specific characteristics that we're looking at that within the making the decision about delivery for our patients. I'm looking at my notes to make sure I didn't have anything else that I wanted to highlight. Okay, next slide. And then last is discharge education. So some of the key principles that they highlight in the toolkit is that every woman and at least one support person should receive discharge instructions on the danger signs of sepsis. That's going to be everyone. So it doesn't matter if she had indicators for infection or not. We want every woman who comes in to deliver to know what the signs and symptoms are of infection and potential sepsis, because we have that category of women post-delivery that come back to us with infection. So we want to make sure, and it's not just mama. I remember my oldest is 19, and I very clearly remember getting home and seeing a folder that I got from the hospital 2 weeks later and said, I don't remember a single thing that they said, and I signed.
Oh, Michelle, you're starting to break up.
Signed my name on these papers.
Michelle, go ahead and turn off your view of yourself if that is on, because we're starting to lose you.
These papers. Right. Yeah. So we have to make sure. Okay, can you hear me? Can you hear me? We have to make sure that we have lots of different ways to make it. Now I've got multiple computers going here. That we have lots of different ways to make sure. I think I can hear. All right, can you hear me? Yes. All right. I'm so sorry. This is why we have backup systems in place. So you can't see me anymore, but you should be able to hear me. Can I get a thumbs up from someone? Okay, good. All right, so where did I leave off? So we had discharge education for all women. We want instructions given at every point of care for ways to decrease infection risk. So for a postpartum nurse, that is making sure that moms are aware of their pericare and frequent hand washing. And then for women who have had a diagnosis of sepsis, then we want to make sure that they have all the appropriate follow-ups. So there's lots of examples of post-sepsis care. What I really like about this toolkit is that they really have brought out the post-ICU and the PTSD syndromes that are possible. And that's not something, honestly, I have thought about in the past, but there is potential for not just cognitive impairment, but if I have a woman that's able to walk out the door and physically looks okay, there are a lot of emotional components to being in the ICU and dealing with severe infection. So next slide. These, of course, are my favorite go-to education tools that can be given out to patients. They are free. You can access them on the website. So on your left is the post-birth warning signs from AWHONN, and on your right is the urgent maternal warning signs that are part of the AIM and Safe Healthcare for Every Woman. So you can access both of those and be able to use that as education. And I think, honestly, if our patients could get this 10 times from 10 different providers, that's all telling us the same importance of how important it is for moms to be able to advocate for themselves and to say there's something maybe not right going on with me, and then be able to be seen. Next slide. I'm not going to spend any time, a lot of time on this so that we can have time for discussion, but I did want to highlight that ACOG District 2 also has some maternal sepsis bundle elements focusing on readiness and recognition, and then response and reporting, which is what we're going to see look similar to the AIM bundles once those come out. Next slide. The ACOG District 2 also does have the list of maternal early warning systems. So if you see Muse out there, that's what this is talking about. And again, it's looking at the same thing that we just looked at with the CMQCC toolkit, looking at specific vital signs. And if she screens positive, then we move into the next kind of identification and treatment. And next slide. So then here's an additional algorithm. So I'm happy to share all of these larger, because I did make them, chop them and scrunch them to make them be able to fit on the screen to share with you guys today. But this, I think, highlights that we've got multiple ways to address, number one, the importance of identifying and quickly treating when we have a potential for sepsis in our pregnant and postpartum women. All right, Dr. Campbell, are we going to use this case, or are you going to use one you have?
No, we're going to use this case. So we'll stop there and ask if there are any questions for you. Anyone?